Welcome back to another episode of Coffee with Coker. For those of you that don't know, Coffee with Coker is a healthcare business podcast published by the Coker Group. And we talk about solutions helping healthcare organizations effectively navigate the changing healthcare industry landscape. My name is Mark Reibold. I'm a senior vice president at Coker Group, and I'm the host of Coffee with Coker. And for this episode, we have another guest that we've had on before on the podcast, and you'll be hearing from Coker's Chief Medical Officer, Dr. Mac Knight. And it's always I always enjoy talking with Dr. Knight, and that he brings a wide range of expertise and experience, not only from the business operations side of healthcare management, but also the clinician's perspective as well, which I know is something that's very important for our audience. So today's discussion with Dr. Knight, we're actually focusing on something that he oversees within our firm, and where we do a lot of work for hospitals, health systems, and private medical groups, and that relates to compliance. And specifically, we're talking about what we call revenue quality integrity, or RQI. And what that includes is everything from coding and compliance, procedural coding in a practice setting, inpatient, outpatient coding for hospitals and health systems, and really everything in between. It also includes a number of other things related to compliance, such as clinical documentation and kind of other elements of compliance in terms of from the revenue cycle management standpoint, as well as all the way through kind of the patient process management. And so we're going to talk more with Dr. Knight here about RQI and coding and compliance, and kind of talk about some of the things he's seen and some of the areas we focus on, but more importantly, where this is most relevant for the clients we're working with and some of the things we've seen out there. So this is a great discussion, and we hope you enjoy it. We always want to remind everyone that you can find all of our podcast episodes at coffeewithcoker.com, or you can go to cokergroup.com and you'll be able to find us there as well. And be sure to follow us on social media, LinkedIn, Twitter at Coker Group. And again, you can always reach us at cokergroup.com. Thanks for listening, and we look forward to coming at you with more episodes here in the future. Welcome back again. We are excited to get another episode of Coffee with Coker going here, and we're even more excited to have back again as a contributor today, Dr. Mac Knight. So welcome, Mac.
Thanks, Mark. Glad to be here.
You were on one of our early on episodes already, and so had a great discussion then, and I know we have some good discussions coming up. Today, we'll jump kind of right into the discussion, I guess, or the topic that we're focusing on today, which is broadly titled what we call revenue and quality integrity, RQI. So for all those listening, anytime we refer to RQI, that's generally what we're talking about. And I think the easiest way to start there is explaining a little bit more about what RQI is. And I'll just say, broadly speaking, in terms of Coker's perspective, we're talking about things related to coding, compliance, and clinical documentation. And so there's a compliance element here. There's kind of a clinical element here, which is certainly something for you, Dr. Knight, that you have a lot of experience and familiarity with. But maybe just start out, Mac, if you don't mind, what is RQI?
Sure. So I think you did a good job of explaining the different components of RQI: coding, compliance, clinical documentation. And really, at one time, we thought about calling it 3C or CCC to take that into consideration. The reason we really chose, however, revenue and quality integrity was to focus on the fact that we are not simply talking here about coding and compliance or clinical documentation for the purpose of optimizing revenues or reimbursements, but we're really talking about trying to get these aspects of hospital and physician practice operations accurate. So what the integrity piece of this implies is that if you're reporting diagnostic codes, if you're reporting procedure codes, if as value-based reimbursements become more and more the norm, you're reporting quality metrics, we want to help you make sure that those different things that you're reporting are as accurate and truly reflect the work that you're doing as accurately as possible. So that's where the revenue and quality integrity piece comes.
Yeah, and something we'll dive into a little bit more here in a few minutes, but also I guess where that ties in, or those terms tie in, is particularly that quality piece where there's kind of a segue over to something I know very near and dear to you, which is, value-based healthcare, value-based reimbursement, and the importance of quality integrity and how that ties back to revenue and operating metrics and performance, the role that those elements play in the value-based realm. And we'll jump into that in a second. I'll come back around to that. I guess as we talk about the 3 C's, if you will, and RQI, talk a little bit more about the coding piece, because you started to talk about, we all know there's different, whether you're talking about procedural codes, you're talking about diagnostics, or you're talking about, inpatient versus ambulatory and everything there. Talk a little bit more about why that's relevant, for the clients we work with, and, how we can kind of bring that home in terms of compliance.
Sure. So coding, fortunately, or as a lot of people would say, unfortunately, is really an integral part of healthcare delivery today. Healthcare delivery, obviously, is a very, very complex undertaking. There are a variety of services that are rendered within any healthcare organization. There are a variety of terms and ways of describing conditions that are used in healthcare. And there are also nowadays a variety of ways to measure performance in healthcare, whether that's around quality outcomes, patient satisfaction, cost efficiency, or risk of certain patients. So in order to make sure that everybody is speaking the same language when they talk about diagnoses, everybody's speaking the same language when they talk about quality metrics, codes have been devised to reflect those different parameters, those different measures, those different components of healthcare. And those codes are the way different organizations, service providers, payers talk to each other and understand that they're talking about the same thing, so that appropriate payments can get made. As we mentioned earlier, appropriate credit can be given for the performance, and appropriate adjustments to things can be made to account for the different complexities and severity of illness of different patients.
Yeah. And you kind of touched on one of the things that I think may be obvious to us and probably a lot of people listening, but the tie back to the revenue piece is that's ultimately how you track the billing process, or that's the initial input on the billing process.
That's exactly right. And what's interesting is that in my professional lifetime, we've always had billing codes related to services, procedure codes, if you will, and billing codes related to diagnoses, ICD-10, or back in the day, ICD-8, ICD-9, and also DRGs, diagnostic related groups, that we've used for those sort of things to report for billing. But again, with the advent of value-based reimbursements, now you come into, not only do you have to explain what was wrong with the patient that you saw, what services did you render, but also what were the quality measures around how well you perform those services. And that's very distinctly different. And there's a whole new coding category to account for quality, cost, and then risk adjustment of those codes as well.
Well, I think that's a critical point, because as we're looking forward, I imagine in your clinical practice over a number of years, you got familiar with the most frequent codes and the different levels or modifiers that we call, in the CPT utilization, those types of things, or on the DRG side. But now you're talking about a whole new world of variables and inputs. And I think what's interesting to me is what happens kind of at the clinical provider level, the clinician level, in terms of your interaction with the patient, and some sort of event or episode occurs, but then it has to go through that process somewhere. So maybe talk about that process, and what I mean is that process is, okay, after that event, how does that kind of process go? And then talk a little bit about the challenge that some of our clients have faced along that process, whether it's, maintaining compliance standards or just making sure that process works efficiently.
Sure. So I like to, and again, I'm oriented this way, start from the clinician's perspective. Mm-hmm. And I always think about that primary care doctor in the exam room seeing a patient in the proverbial 15-minute patient visit slot. So in that 15 minutes, think about this. The physician has to render care to the patient by taking an accurate history and physical examination, formulating an assessment and a plan. He or she has to document that accurately, because that's where all these codes and different measures get extracted from. He or she has to communicate that information to the patient. He or she has to then select the appropriate codes to go with the level of service that they just provided. And there's 5 levels of service for that type of a procedure, which is called a evaluation and management, or E&M code. He or she has to also select the diagnoses that go along to support that bill, that level of service. And gosh, there's literally hundreds of thousands of ICD-10 codes that can be applied to that. And then last but not least, in recent times, now they also have to select and capture and document appropriately what are called HCCs, or hierarchical clinical conditions, which are used to risk adjust the quality and cost metrics that provider may be getting paid on, based on how severely ill their patients are on average, how complex they are. So you take that 15-minute visit, and there's a lot that has to happen. Then even after that visit is complete, as you said, there's a whole process that goes on beyond that, where those codes, that clinical documentation, is translated into a bill, into an invoice that the provider sends to the payer. The payer then uses those codes and that information to determine how much the provider is paid, and they send that reimbursement back. And there's literally hundreds of things that can be culled out of that whole process that can go wrong, that will cause the invoice to be rejected or the payment to be refused. So it has to be accurate. And last but not least, it has to be done in a compliant fashion, because you don't want the CMS OIG coming down on you, or any payer coming down on you saying, you overcharged for the service that you actually rendered. So you have to do all that coding and documentation but you got to make sure it's right so you don't get fined or even worse for doing it wrong.
Yeah, and the reality is those, whether it's fines or other, regulatory issues, those happen every day.
Sure.
And so it's not like this kind of mythical threat. These are, whether it's flat out fraud, Medicare fraud, or it's seemingly honest, simple mistakes, that there's just some lack of efficiency in the process, which brings up kind of the next point is, so one of the things we've done as Coker for years for our client is coding audits. Maybe just walk through that process real quick, because this is something obviously that's very much compliance related. And, without making this overly salesy, I want to make the point of why is the chart audit relevant, and more importantly, what's the value of it other than just checking one more thing off the compliance list?
Sure. So, we do a lot of that sort of work, and you can really break it down into both the outpatient or ambulatory area for professional services and professional fee audits. Or you can also do, and we do quite a bit of this, of technical charge audits, where we go in and look at, certain departments of the hospital or outpatient services that are rendered. And on the technical side, on the facility side, are the codes that are being used appropriate and accurate? But the most common audits that we do are in that E&M arena on the professional side. So what we do is we come in, we select at random a number of charts for each provider. We look through those. We have certified coders that do this all the time. They know what to look for in terms of the documentation requirements to support those codes. And then they can look at the medical record, usually remotely, because most medical records are now electronic, so they can access those systems remotely. They read the record. They look at the codes that were derived from that record, either, again, service codes, E&M codes, or diagnostic codes, and they determine whether that was done accurately or not. After that, then, the provider is scored in terms of their accuracy level, and usually ones that score, and it's somewhat arbitrary, but usually we set an 80% cutoff, and if they're less than 80% of the time accurately selecting CPT or ICD-10 codes, then we do education and training on those providers to try to get them up to speed and try to improve that. Which,
again, goes to the point I kind of alluded to earlier, that the majority of these cases aren't blatant fraud. Most of these cases, the far majority of these cases, are our client oftentimes being brought in, we being brought in by their legal counsel, just kind of saying, hey, we want to make sure we're doing everything right. First of all, we want to get this right and look at it from making sure we're within the white lines and all of that. And we can help kind of build that compliance program, if you will, or at least that element of a compliance program. Then they can think about, how can we make it more efficient? Is there some skewing of a bell curve towards undercoding or overcoding? Are we in a reasonable sweet spot? And so it is a little bit fluid. There's some fluidity there that you kind of have to evaluate each case. Part of it seems to be very technical, and that's why I know a lot of the folks on your team are not only are they professional coders, but they're clinicians as well that can look at it from that perspective. But I just think that's an interesting point, that a lot of times the scenario is more, hey, let's just make sure we're doing this right, and then we can think about optimizing it or
that's right.
Improving.
And I think the having clinicians do this, and most of our coders are RNs and do have a clinical background. It really helps, because the the whole trick to this, I like to say, is a translation process. So, it's almost like translating one language to another. And if clinicians speak one language and coders speak another language, and you don't know how to accurately translate clinician language into coding language, then you're going to have errors and problems. So that's where having clinicians do the coding reviews really helps, and the education, because they can say, I know that this is how you learn to say this in medical school or in nursing school, but for coding purposes, this is the language that you need to say it in. And it sounds kind of nitpicky and nuanced, and sometimes it gets some pushback from providers who say, well, that's not the way I learned it. But the truth of the matter is, again, if everybody's going to be saying that code or that phrase means what we all say it means, you've got to have uniformity and you've got to have standardization.
That's right. And in my mind, absolutely no offense meant towards our attorney friends out there, but the last thing you want is to be in some sort of review or even investigation process and an attorney trying to make that translation. I would much rather go ahead and have that addressed on the front end, and that'll save you a lot of time, frustration, and money probably as well.
Yeah, the compliance piece of this, I think, is very, very important. And we like to tell our clients that the best way to be compliant is to, and most organizations have internal auditors and do internal audits, and that's great. But to bring in a third party, a disinterested third party that can look at this and make sure you're doing it the right way, even if problems are identified, then after the fact, if the payers or regulators come in and say, okay, here's a problem, you can demonstrate that you found it, that you identified it, that you're trying to do something about it, that you put education and training into place. Just ignoring it and letting things go, I think, is where things really get into problems. And then you mentioned the few providers out there that just willfully do things incorrectly in order to practice fraud and abuse. Luckily, we don't run into many of those. But again, if you don't want to have somebody that is trying to do things correctly get unfairly accused of that as well.
Yeah, it's much easier to weed those bad apples out sooner too, as long as everybody's on the same plane, same standard, and there's regular kind of checks. I think can't emphasize that point enough. And one of the other things I think there is the intentional or proactive mindset on this, and we've seen that become much more of impetus, I think, from a lot of our clients in recent years, because again, there may be a way that you've done this, the clinician may have been trained, or the way you've kind of done it up to this point. But two things we know: first of all, it continuously changes and evolves, and I think it's only becoming more complex as it does so. And then the other point is, while we love our EMR vendors out there and the technology that's being developed from an IT and IS perspective is doing wonders in our system. That being said, we're nowhere close to these systems being able to cover every variable for us as it relates, particularly as it relates to coding. So there's no magic EMR solution or practice management system solution that can fully just kind of take care of this for you, and to the point where you can just wipe your hands, essentially.
Right. Well, those are two great points, and let me kind of touch on both of them and tell you that some of the issues that we run across all too frequently are, number one, because, as I know all our listeners know, more and more physicians are paid based on worked RVUs. And worked RVUs are derived from these procedure codes that we were talking about. So each CPT code is worth a certain number of RVUs. Well, if you have physicians, and again, I'm not saying this happens a lot, but it does happen, who are systematically and regularly upcoding records so as to increase not only reimbursements, but their compensation through that RVU mechanism, that's a problem. And these reviews and audits can catch that sort of thing. The other thing that we see on a fairly regular basis is, interestingly enough, the unintended side effects or consequences of introducing electronic health record systems into this process. So we see notes that are cut and pasted and templated and reproduced every day. Again, this doesn't speak very well for my profession, but I have seen hospitalists like myself who you look at their daily notes in the electronic health record and they're exactly the same. Why are they exactly the same? Because they are exactly the same. They're cut and pasted from one day to the next to save time and to...
Well, the system allows for it.
And the system allows that to happen. But again, that's a big no-no. It may make the provider's day a lot easier and quicker, but you get caught with that, and those are one of those red flags that can get you in trouble with the regulators and payers. So.
That's a great example, and also a great example on the how this relates to the whole RVU piece, because I know talking about physician compensation, the way of measuring productivity and how that relates to a comp plan for an employed physician, for instance, not only is there some of that abuse, but we've also ran into cases, I know, where clients there's something slips through the cracks. So, for instance, I know we worked with a hospital one time where, when they kicked off this one employment contract with a physician, it was based on the Medicare fee schedule for whatever that year was, the latest published date. Well, it wasn't getting updated. The Medicare, obviously, CMS releases a new fee schedule every year. And so CPT utilization and how that translates into or converts into RVUs changes. And that's something their comp plans has to adapt with and incorporate. And so, that's going to change what ultimately, the outputs in terms of compensation or payments. And that's another compliance element. And that's kind of, maybe that's beyond coding or chart audits and that specific process, but I think it's just an example of how it all ties together.
Well, you mentioned the complexity of the whole system. From ICD-9 to ICD-10, we literally went from tens of thousands of diagnostic codes to hundreds of thousands, tripled the number of diagnostic codes. Some specialties, orthopedics, for instance, it just got crazy in terms of the number of ways to describe a fracture of the wrist or the hand. And what that does then is, again, it makes compliance much more difficult because you want that to be the most accurate description possible of what you're dealing with. But unless you've got some system, some way of doing that in an automated fashion, there's nobody in the world, I would say, that could keep all those, even for one specialty like orthopedics, all those codes in their head.
Sure.
It's just, they're not
too,
around.
Too much nuance and too many variables there. Let's talk for a second about the third C, if you will, in this whole discussion. But I guess give us a high-level rundown on clinical documentation and CDI, clinical documentation improvement, and then we can talk about how that ties back to the kind of the whole picture of RQI.
Sure. So again, I like to say that clinical documentation is really the foundation for all of this. It's really, when you think about it, the foundation. and the very, very front end of the revenue cycle. So what the provider documents in the medical record, whether they do that with pen and paper or whether they do that electronically, is the documentation that then gets interpreted into diagnostic codes, procedure codes, risk adjustment codes, etc. So the way that you document, the amount that you document, the specificity of what you document with regards to the history of present illness, the past medical history, social history, physical examination, assessment, and plan, all gets taken into consideration, and the different elements of that are looked at to justify certain codes. It's a record, if you will, of not only what was wrong with the patient, what was done to the patient, but the services that you rendered to that patient. So it's got to be accurate, it's got to be complete, and quite honestly, that's just not something anybody, at least in my era, was ever taught in medical school. I quite honestly don't know nowadays if they teach that, but I doubt it because, again, it does change and it is altered on a fairly regular basis. But that's the main thing that we focus on in our educational services with regards to revenue and quality integrity is we go in and we say, well, doctor, we reviewed your cases and 90% of them were either level 4s or level 5s, but in looking at the documentation that you're providing, it looks like they should have been level 2 or level 3. What are we looking at here? What if they're truly higher level patients, what do you need to document to satisfy the documentation requirements for that? Or if they're not those higher level patients, why should you drop the code assignment? So clinical documentation, I mean, ideally, I would like to say that the medical record is a communication tool between providers, but the reality of it is the medical record is also a tool that triggers billing, triggers quality reporting, it triggers tracking of services and diagnoses. It's much, much more than just here's what I did today. Somebody can come behind me and figure that out. Mm-hmm. I remember my dad, who was the only doctor in this little town I grew up in, out in Idaho, used to keep his office notes on 3x5 cards. Mm. And his standard note would say, Mrs. Jones, sore throat, penicillin. Well, he would spin in his grave today if he knew how clinical documentation has changed, the requirements for same, the billing things that are triggered off of that. It's just a whole different world in terms of that kind of paperwork requirement.
I was going to say, how many reams of paper would be needed for Mrs. Jones, that penicillin prescription today?
Exactly.
Well, that's really interesting because I think there is an element of CDI, the clinical documentation piece, that is there's a kind of compliance element there to it. It's we have to make sure the 4 or 5, level 4 or 5 versus the level 2 or 3 that should be that kind of scenario. It seems like there's also an optimization opportunity there as well, because sometimes you get the other way where it seems as though a trend for maybe one provider is relatively low, and we know there are those out there that undercode because they're just either conservative, that's how they were trained, or maybe they're legitimately concerned about the whole compliance piece, and so they just rather safe than sorry type thing. But that can be an issue too. Not only compliance, there's compliance issues there, obviously, but there's also revenue losses.
Well, that's absolutely true. I'm a hospitalist, and most hospitalists aren't paid on RVU basis. They're paid on a shift basis or a per hour basis. And so one of the things that I see a lot in hospital medicine is providers who just default to a lowest level. It requires you to document the least. It is quicker. The cut and paste thing plays in there too. And the problem with that is that may be the quickest way and the most simple way for the physician to kind of get through the note and the patient visit. But then the facility is getting shortchanged because not only does the physician fees key off of that documentation, but so do the facility fees. So what happens is there's a coding process. They go through and they say, well, it looks like this patient's in the hospital for pneumonia. Well, is it aspiration pneumonia, or is it gram-negative pneumonia, or is it simple community-acquired pneumonia? Those few little words can mean thousands and thousands of more dollars for the facility because it costs more to take care of patients with those more complicated types of pneumonia. And again, that's something most providers don't really kind of register with them.
Yeah,
it's
sure.
like, well, I know it's pneumonia.
Yeah.
I know what kind of pneumonia it is. Why do I have to write it down? Well, you have to write it down because the DRGs for aspiration pneumonia pay a lot more than the DRG for simple pneumonia.
Yeah, good point. Yeah, that's a good example. I'm going to put you on the spot for a second because I really like to get your perspective on this. We specifically, I'd like to get your perspective because you bring the clinical aspect as well as kind of the operational perspective. But obviously, right now, hot button topic, the opioid crisis and everything that goes with that, right? Specifically, though, I think it's somewhat tangential to the subject, but I also think it's related. I was at a conference recently talking to one of our attorney friends, and we're talking about this opioid crisis, and the discussion kind of came up, and I made the point that I think the majority of your physicians out there that prescribe pain meds, let me put it this way, the pill pushers, I think, are the exceptions.
Right.
Just like the Medicare fraud guys,
right.
To a certain extent. I don't know what the breakout is. That's all speculation. Obviously, it doesn't matter. But and I think in most markets, the community, the medical community within those markets have a pretty good idea of who those bad apples are. At least they can suspect it. But I think what we're starting to see as this issue continues to grow and get more attention, concern pop up and potentially even legal issues or questions pop up about what I would involving providers that are 100% legitimate, well-intended, not intending to get caught up in this whole mix. But, and this is where the attorney at that conference kind of made this point to me that even good intentions, though, if they don't have the backup to support it, the compliance programs that are in place, and that means everything from coding to billing to documentation, and probably a lot of other things in that mix as well, then you're potentially exposed. What are your thoughts on that whole issue?
Well, it's a pretty big issue and probably require longer discussion than what we've got time for this afternoon. But I think you're right. I think it does play into this, and it plays into it, in my mind, from the quality reporting and the pay for performance and the value-based reimbursement. So if you go back a few years ago, one of the big things that providers were judged on, their performance through patient satisfaction services or surveys, was how well was your pain controlled? Mm-hmm. So a patient comes into the hospital. Again, I'm a hospitalist. I'm taking care of that patient. When they go home, they get a survey. And did Dr. Knight prescribe the appropriate pain medication to control your pain? Well, can you do that and at the same time risk exposing a patient to potentially addictive substances? Absolutely. And as we all know, most opioid addicts are, started out through prescription pain medications.
Sure.
They didn't start out by going out and abusing heroin and street drugs.
Right.
They used, OxyContin and MS-Contin and other things like that until then they couldn't get those any longer, so they turned to heroin or even other street medications. So, was there unintended consequences of this emphasis? I mean, we've all seen the smiley faces on the, nursing notes, and, was it a 0
pain level,
in
right,
pain to a 10? Well, you get everybody up to a 10, down to a 0, there's going to be some unintended consequences of that, even in the best practitioner's hands. And it's a difficult kind of line to walk. So, how does it relate to coding and compliance? Well, again, we all want to get rated high. We all want to have our survey scores be excellent, but we don't want to be churning out people who are addicted to prescription medications either. So it's a problem.
Yeah.
It really is.
Well, I think it does tie back to the value-based care discussion as well, because again, if you can get to a point where you're truly managing patient care and doing it in a way that fits within this whole system, meaning the whole value-based model, there are also alternatives out there, so that it may not need to be the kind of traditional prescription route, but there are other solutions or at least alternatives that don't always work in all cases. But as long as the clinician has the flexibility to offer those alternatives, and they can get reimbursed for it, they can get whatever the appropriate incentive is to do that. But you certainly don't want to handcuff them to the point where they're having to make a decision on a clinical decision, and I'm not saying just in this case, but any clinical decision based on something other than what's best for the patient.
Well, I totally agree, and I the other buzzword in healthcare today is patient-centered care. And don't get me wrong, I am all for patient engagement, and I think the paternalistic approach that providers have taken in healthcare for long time needs to change. But you have to also say we can't swing too far over to the other side, because there's a reason why you've got professionals, you've got hopefully knowledgeable, considerate, compassionate, and reasonable professionals advising and involved in the process. Otherwise, healthcare really can't be self-service, because again, there's pros and cons to almost everything you do, and you have to have somebody that can help you kind of guide through that decision matrix.
Yeah, good point. So I guess in bringing this back full circle, I think we talked about the link between RQI and all that includes, and not only kind of the volume-based model, but where we're ultimately at least directing towards value-based care. But maybe if you could, just if we can bring it full circle, and I don't know, maybe talk through it if you have a case study or example of where we've kind of been able to work, whether it's a hospital or group or whatever, and not only look at this from a compliance standpoint, but from a value optimization standpoint, and where coding or if it was just coding or CDI or maybe the whole mix comes into play. Any thoughts there?
Sure. So a couple of examples. We work with a large healthcare system in another state and do really routine, regularly scheduled audits and reviews of all of their employed providers, which number in excess of 300 on a regular basis. We rotate through the different specialties, space them out, And then we do education and training, as I mentioned, for those that fall under that. And it's neat to see as we do that how the performance overall improves. And again, I'm not talking about performance in terms of, well, the hospital makes more money. I'm talking about the hospital has a more accurate coding assignment going on, and they're at less risk of regulatory or legal
so
jeopardies for that.
We're tracking it over time, is what you're saying?
Yeah. That's right.
Yeah.
And, and they've even had during that time some instances where payers or CMS will come in and say, we're concerned about this, and we focus in on that, and we're able to proactively do some auditing and education and improvements to avoid getting them into a jeopardy with the payer. The other example I can give is that we've done several clinical documentation improvement program developments, and that's a huge benefit to hospitals. And I would actually say if there's any hospitals out there that don't have a CDI program, especially on the inpatient side, but also on the ambulatory side, which we're doing more and more of, you really ought to consider that because, again, everything keys off that clinical documentation. And if your clinical documentation is not being done right, everything downstream from that, the coding, the billing, the collections, is going to suffer. So getting clinical documentation right is very, very, very important. Is it easy? Do providers take kindly to being told you can't call something the way you've called it ever since you were in medical school? No, they don't. But again, is it important to try to do that? And are there ways to do that that are more acceptable and accepted by providers? There definitely are, and we can help with that as well.
Yeah, it's such a foundational element because, like you said, if that linchpin is loose there, then there's no telling where other things could be either exposed from a regulatory standpoint or legal standpoint, or just less efficient, less optimized. One of the other examples I even thought about was me coming from a kind of a transaction background, doing a lot of mergers and physician alignment deals, things like that, is the importance of this in a due diligence program.
Correct.
So, for instance, if it's a hospital or health system doing alignment deals with physician groups, and you're talking about employing new physicians, part of the due diligence process, yes, is it's kind of it's part of just quote unquote due diligence, but there's also an integration element to that as well to help understand, okay, are their practices consistent with what we have, what we need, what we expect, what we require at the health system level? What, if anything, needs to change? Maybe that's just some simple education and training, like you alluded to. Maybe there's something, significant there that needs to be more specifically addressed, not, wrongdoing or fraudulent or major red flag, but at least it's frequent enough to where it's like, okay, a conversation, some training, maybe we need to set something up in the systems to help accommodate. And addressing those things on the front end is so much, as kind of you alluded to, it's not always easy, but it's way easier, way simpler to go ahead and address that on the front end as opposed to having to deal with it when it comes back full circle on the back end. Well,
that's right. And, we do, as you're well aware, lots of valuation work.
Mm-hmm.
And, a lot of valuations are done on the basis of on a discounted cash flow basis.
Sure.
And if your cash flow is way off because you're not clinically documenting right, therefore you're not coding right, therefore you're not billing right, therefore you're not collecting right, that can give you a very false impression about the viability of this practice or hospital that somebody's looking at acquiring. So it is very important. I mean, it's a silly kind of analogy, but if you were going to go buy a car dealership and you found out that all the paperwork for selling the cars and getting them paid for and all that sort of stuff was just wrong, you wouldn't put much money into buying that car dealership.
Mm-hmm.
And healthcare providers, whether they're hospitals, health systems, physician practice, same thing. I mean,
Mm-hmm.
it's there's a lot of nuanced issues, especially in healthcare, that need to be addressed.
Yeah, absolutely. And it's only getting more. There are only more complexities coming into it. So I feel like, that's something that it's kind of inevitable. We're going to have to address it, and we're going to have to continue improving on it. So, well, listen, Mac, I appreciate you having this discussion. I thought it was extremely helpful walking through the overarching perspective of revenue and quality integrity, and specifically drilling down onto the coding, the compliance, and the clinical documentation components of that. And of course, I'm sure we'll have plenty of follow-up discussion on this, and maybe even drill down on some specific areas or questions as listeners have them. But thanks for coming on, and we look forward to having you on the next one.
Well, thanks for having me. Appreciate it.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.